This conference will now be recorded.
Okay, today's topic is epilepsy in pregnancy. So epilepsy in pregnancy is important because epilepsy will cause more morbidity and mortality in mother, whereas anti-epileptic drugs are equally dangerous to the baby as epilepsy for mother, causing congenital defects. Most of them are not safe in pregnancy, but we cannot avoid anti-epileptic drugs because mother's safety is more important than baby. We'll shift the mother to the relatively safe drugs to maintain a moderate safety for mother and baby. So, coming to the definition, a seizure is defined as paroxysmal disorder of central nervous system characterized by an abnormal neuronal discharge with or without loss of consciousness. I think you all know these definitions better in medicine. Just a brief introduction. After headache, seizures are the next most prevalent neurological conditions encountered in pregnancy, and they complicate 1 in 200 births. Epilepsy is associated with increased maternal deaths. This is our main concern. So this is why epilepsy in pregnancy is very important, according to the mother. And use of anti-epileptic drugs is associated with increased risk of major congenital anomalies in fetus. So we are concerned of epilepsy in mother and anti-epileptic drugs in the baby. Coming to pathophysiology, the International League Against Epilepsy Commission on Classification and Terminology 2014 classified as focal seizures and generalized seizures. Focal seizures originate in one localized brain area and affect functions of corresponding area. Occur due to trauma, abscess, tumors, or perinatal factors. So again, focal seizures are divided into two types: focal seizures without cognitive features and discognitive features, and focal seizures with discognitive features. First one starts in one region of the body and progresses toward the other ipsilateral area of the body, producing tonic and then clonic movements. Simple seizures can affect sensory function and produce autonomic dysfunction or psychological changes. Cognitive changes or cognitive function is not impaired and recovery is rapid. So among focal seizures and generalized seizures, focal seizures are safe. Among these two types, focal seizures without discognitive features is safe. And next type is often preceded by an aura and followed by impaired awareness manifested by sudden behavioral arrest or motionless stare. Involuntary movements such as picking movements or lip smacking are common. Next type is generalized seizures. These involve both brain hemispheres and may be preceded by an aura before an abrupt loss of consciousness. There is a strong hereditary component in these generalized seizures. Usually these seizures run in families. Loss of consciousness is followed by tonic contraction of muscles and rigid posturing, and then by clonic contractions. You all know this. Tonic clonic seizures means first tonic contractions will occur, then clonic contractions of the extremities while the muscle is gradually relaxed. Return to the consciousness is gradual and the patient may remain confused and disoriented for several hours. So generalized seizures are more dangerous, and this will affect more. This will create more effect on maternal morbidity and mortality. Another one is absence seizures, also known as petit mal seizures. Form of generalized this is also a form of generalized epilepsy. Is a special category that involves a brief loss of consciousness without any muscle activity, or characterized by immediate recovery of consciousness and orientation. Coming to causes of the seizures in pregnancy, pregnancy-induced causes and other causes. Pregnancy-induced causes we all know is eclampsia and complications of regional anesthesia. These are rare nowadays. Eclampsia is more common. Other causes of seizures are epileptic seizures, CNS infections, metabolic causes, and tumors and masses. and anti-epileptic drugs withdrawal or overdose, illicit stimulant drug use, alcohol or drug withdrawal, trauma, hemorrhage, thromboembolism, and psychogenic non-epileptic seizures. We also known as this is also known as pseudo seizures. These are the common causes in pregnancy for seizures. So this is important. What is the effect of pregnancy on seizures and epilepsy on pregnancy? So first one is effect of pregnancy on epilepsy. For majority, 50 to 80% of seizures frequency is unaltered. So pregnancy do not aggravate any seizures in 80%, 50 to 80% of the cases. That means majority of cases, pregnancy will not show any effect on epilepsy. With seizure free interval of 9 months to 1 year before conception, there is 84 to 92% probability for seizures free during pregnancy. So if a woman didn't get any seizure for a period of 1 year, there is very less chance for her to get a seizure during pregnancy. Women with more than one episode of seizure per month are at annual risk of more than or equal to 1% of sudden unexpected death in epilepsy. So these patients are very important for us. If patient is having more than one seizure per month, there is a chance of sudden mortality. There is insufficient data if pregnancy changes frequency of seizures or increase in status epilepticus. But according to our knowledge, in most of the cases, it will not affect, pregnancy will not show effect on epilepsy. Greater seizure frequency is often associated with subtherapeutic serum anticonvulsant levels or lower seizure threshold. So risk of seizures high during peripartum due to hyperventilation, pain and stress. These are the provocating factors in peripartum period. Due to pain, stress and hyperventilation, it may trigger an episode of seizure. Coming to physiological changes in pregnancy and effects on anti-epileptic drugs. Anti-epileptic drugs metabolism varies greatly by individual, and each patient has their own therapeutic drug level at which seizures are controlled. So we have to increase the dose of these drugs till the patient reach this therapeutic level to control the seizure. It is important to understand and establish this drug level prior to pregnancy because levels of anti-epileptic drugs can change during pregnancy, and decreased levels leads to loss of seizure control and triggers an episode of seizure. Coming to physiological changes of pregnancy and consequence on anti-epileptic drugs. In pregnancy, total body water, that is extracellular fluid, body weight and estrogen levels, all this will increase and alters drug distribution and low serum levels. So we have to adjust the serum concentration of AEDs according to the individual patient's requirement. And there will be increased cardiac output, which in turn increase the hepatic blood flow and increased elimination of AEDs. And there will be increased renal blood flow and increased glomerular filtration rate. So there will be more renal clearance. And cytochrome P450 activity altered and altered systemic absorption and hepatic elimination. And maternal albumin will decrease. Availability of free drug for hepatic elimination will increase, and nausea, vomiting will result in decreased absorption. So these are all the physiological effects of pregnancy, which will affect AEDs and their doses. So we have to consider all these factors, and we should reduce the dose of the AEDs to control seizures. Coming to effect of epilepsy, maternal effects and maternal effects are preeclampsia and gestational hypertension or spontaneous abortions. There is insufficient data that epilepsy will cause these things in pregnancy. There will be moderate increased risk of hemorrhage in late pregnancy and premature labor, delivery in smokers, and cesarean rate will increase. Trauma maternal death rate increase by tenfolds. Postpartum hemorrhage and postpartum depression will increase. These are the maternal effects. Effects are seen in women with epilepsy taking anti-epileptic drugs. If epilepsy in pregnancy is controlled without anti-epileptic drugs, these effects will be very, very minimal. Above discussed effects are mainly on the woman with epilepsy taking anti-epileptic drugs. Effects on fetus and neonate. Congenital malformations, IUGR, prematurity, stillbirths, hypoxia, low Apgar at 1 minute, risk of trauma, cognitive impairment, and neonatal coagulation defect. Next one is epilepsy, effect of epilepsy and AEDs. Genetical and fetal environmental circumference or poorly controlled epilepsy will lead to congenital malformations, CNS maldevelopments, which in turn leads to impaired cognitive development. Cognitive impairment more common with valproate, frequent tonic-clonic seizures, prolonged poorly controlled temporal lobe epilepsy. So these are effects on the child. So effect of epilepsy and AEDs. It is difficult to define the relationship whether malformations, poor neurological development are due to epilepsy or AEDs. Pregnant woman not on AEDs, no evidence of increased risk of malformations or cognitive development impairment, but could not be ruled out. Effects are more with increased dose of drugs. Effects are more with polytherapy than monotherapy. Generally, we will shift the mother before planning for pregnancy from polytherapy to monotherapy if possible. If patient is having an episode of seizure and was not maintaining on monotherapy, will again shift for polytherapy because maternal safety is more important. AEDs interfere with synthesis of vitamin K dependent clotting factors like 2, 7, 9, 10 directly and by inducing microsomal enzymes that degrade vitamin K, resulting in neonatal coagulation defects. So women taking AEDs always the baby should be given a vitamin K prophylaxis as soon as birth. And effect of epilepsy and AEDs. Timing of malformation associated with the AEDs, neural tube defects. It is the earliest congenital malformation to occur. It will occur on day 28 after conception. This is very, very early. That is 2 weeks after missed period. Cleft lip. This will occur in day 36. And a BSD. This will occur on day 42. Cleft maxillary palate. This will occur in day 47 or day 70. Coming to teratogenic effects of common drugs. First one is valproate. Neural tube defects, cleft lips and cleft palate, cardiac anomalies, polydactyly, hypospadiasis associated with developmental delay. Effects are 10% with monotherapy and higher with polytherapy. Next one is phenytoin. Fetal Hydantoin syndrome is more common. This will account for 5 to 11%. Carbamazepine also cause fetal Hydantoin syndrome and spina bifida. This will account for 1 to 2%. Phenobarbital, clefts, cardiac anomalies, urinary tract malformations. This will affects in 10 to 20%. Lamotrigine increased risk for clefts, that is 1%. Topiramide, cleft lip or parrot will occur in 2 to 3%. Levetiracetam is relatively more safe in pregnancy. There is only theoretical risk of skeletal abnormalities, impaired growth in animals, but there is no any proven abnormalities in human. Coming to fetal Hydantoin syndrome, the baby will be like this with upturned ears, midfacial hypoplasia, long upper lip with thin vermilion border and cleft lips. This is spina bifida. This is a spina bifida occulta, and this is a meningocele. Only membranes will be bulging, and this is myelomeningocele with membranes. Also, spinal cord will be tethered with the sac. This is more dangerous and complicated anomaly. Coming to preconceptional care and counseling, risk and teratogenic effects of drugs should be explained. Risk decreases with planned pregnancy with the lowest effective dose of anti-epileptic drugs with folic acid. Folic acid supplementation with 0.4 mg per day is begun at least 1 month before conception, and dose is increased to 4 mg when the woman taking anti-epileptic drugs becomes pregnant. So generally, routinely will give 0.4 mg. If the woman is on anti-epileptic drugs, we'll increase the dose to 4 mg. Before pregnancy, serum drug levels may be useful for monitoring and comparison. Generally, due to physiological effects of pregnancy, there will be increased dose requirement in pregnancy. So we should check for baseline serum levels of AEDs so that we can monitor and adjust accordingly. So, drug withdrawal before pregnancy, women with mild and infrequent seizures and seizures free for many years on medication, we can try for withdrawal. Withdrawal by slowly tapering the drug, not faster than 2 to 3 months. So we should not stop the drug abruptly, which will trigger another episode of seizure. We should taper the drug for 2 to 3 months with one drug being tapered at a time. If the patient is on polytherapy, we should not taper 2 drugs at a time. We should taper one first and the next the later one. Withdrawal of AEDs for at least 6 months prior to planned pregnancy. With withdrawal, risk of seizure recurrence is 40% in first 2 years. So we should withdraw the drug very, very carefully. Women who abruptly discontinued AEDs for few weeks should not be considered to have successfully withdrawn from therapy, should resume therapy and then taper over time. Precautions are avoid alcohol, high doses of antidepressants, avoid triggering factors like flashing light, sleep disturbances or deprivation. AED switching. Lamotrigine and levetiracetam are now the most commonly prescribed AEDs for women of childbearing age, as they are associated with less malformation risk. So valproate is having highest risk. Next comes the phenytoin, phenobarbital and topiramate. So carbamazepine is relatively safe next to the levetiracetam, phenytoin and phenobarbital, and then comes the valproate. So valproate has a maximum risk, that is 4 to 8 folds higher for major anomalies. So it is safe to avoid valproate and shift to the safer drugs before planning for the pregnancy. Genetic counseling, average the risk of passing on epilepsy is 2.69% to 8%, higher than normal population, that is 1 to 2%. Risk more with generalized seizures than focal seizures. As we already discussed, generalized seizures will run in families, whereas focal seizures are mostly due to local causes like trauma, tumors, etc. Increased risk if first degree relatives are affected. Mothers with epilepsy have a much higher chance of having a child with epilepsy than do fathers with epilepsy. So mothers will transfer to the baby than the fathers. Pre-implantation genetic testing for genetic disorders is available only for some syndromes, and it is controversial. So pre-implantation genetic testing will not detect all the disorders. So generally we don't routinely advise for this test. Coming to genetic disorders, idiopathic generalized epilepsy, autosomal dominant frontal lobe epilepsy, and autosomal dominant temporal lobe epilepsy, sodium channel voltage gated type 1 alpha subunit, gene mutation, and bilateral periventricular nodular heterotopia. These are types of seizures, as we already discussed, tonic-clonic absence and juvenile myoclonic epilepsy, and focal seizures. Coming to management. In first trimester, generally we'll prescribe folic acid supplementation if the epilepsy woman is on AEDs. The dose is 4 mg. Treat nausea and vomiting with antiemetics. Ensure compliance for AEDs. Monitor total and free plasma drug levels and dose adjusted if necessary. Drug monitoring it should be done early in pregnancy, end of first trimester, and if any seizure activity occurs. Coming to screening, at 16 weeks, we should screen for serum alpha fetoprotein. Generally, it will increase in neural tube defects. And at 18 to 20 weeks, we should do a TIFA scan or anomaly scan to rule out any clefts or neural tube defects. At 20 to 22 weeks, we should do fetal fetal ECG to rule out cardiac anomalies. In second and third trimesters, AED doses adjustment according to the weight and serum drug levels. Continue folic acid tablet. Generally, we'll give folic acid tablet for normal patients only first trimester. In this epilepsy patients on AEDs, we should continue folic acid in second and third trimester also. Add another drug if seizure occurs in spite of high serum drug levels. Oral vitamin K 10 mg OD given during last 4 weeks of pregnancy, particularly with enzyme-inducing AEDs. To prevent hemorrhagic disease of newborn, no proven efficacy. It is theoretical. Antepartum fetal evaluation with NST is not necessary in all mothers with seizure disorders, but it should be considered for patients who have active seizures in the third trimester. Management in labor. Induction of labor or cesarean delivery in a woman with epilepsy should not be recommended without specific additional obstetric or medical or neurological indication. We generally do not do routine cesarean section or induction of labor for all patients. It is depending on their obstetric need. Elective cesarean section may be considered in patients refractory to treatment during the third trimester or in those with status epilepticus and significant stress, because these patients will not tolerate a normal delivery stress or pain. Repeated seizures that cannot be controlled may require an operative delivery. The risk of seizures during labor in women with epilepsy is 3.5% or less, and seizures are more common in patients who had seizure during pregnancy. An epidural analgesia can be considered early to minimize precipitating factors for seizure, and switch of oral medication to IV 48 hours before delivery. AED dose should not be missed during labor. For women on oral phenytoin, continue the same dose intravenously. If the woman is on a different anticonvulsant, phenytoin loading dose is given, followed by maintenance dose twice daily intravenously. In case of active seizure during labor, assess respiratory and circulatory function. Nothing should be put in mouth of seizuring patient. Supplement oxygen and suctioning of the secretions can be performed. The patient should be kept in left lateral position. Lorazepam of dose 0.1 to 0.2 mg kg per kg at the rate of 2 mg per minute should be given, or IV diazepam should be given. If the seizures does not resolve, fosphenytoin or phenytoin 20 mg per kg IV should be given. This is the treatment that should be given in active seizures. Acute seizures. Fetal monitoring should be begin as soon as possible after a seizure. Transient fetal heart rate changes may be seen and they are temporary. If fetal bradycardia persists, chances of fetal compromise or presental abruption and must. In this case, we should must proceed to cesarean section. Coming to postpartum management. 3% of the women are at increased risk of seizure within 24 hours of delivery. Prophylactically, clobazam 10 mg OD or BD can be given for a woman at risk. Triggering factors for seizures or sleep deprivation, stress, pain, fever, and dehydration, and these should be avoided in postpartum period. Generally, sleep deprivation and stress and pain, dehydration are more common in postpartum period. We should avoid this. Dose of AIDs should be decreased over 3 weeks after delivery to preconceptional doses. So always we should taper the dose. Never abruptly change the dose to another dose. Neonate should be given vitamin K injection 1 gram IV. Sorry, 1 mg IM. Postpartum period. Postpartum safety advice and strategies. Seizures can result in accidental injury to the mother and baby. Strategies are nursing the baby on the floor. So this will avoid the slippage of the baby from mother hands when mother is on the bed or any chair. So if the nursing the mother on floor, this will reduce the injuries to the mother. Using very shallow bathtubs, laying the bed down, laying the baby down if there is a warning aura for mother. Not bathing the baby unaccompanied. Wearing identification tags and avoiding sleep deprivation. Coming to management in breastfeeding, women taking AEDs should be encouraged to breastfeed, given the well-known benefits. When breastfeeding is stopped, the infant should be weaned slowly. Given the potential for withdrawal symptoms, infant safety advice should be given to prevent trauma at the time of seizures. All AEDs are excreted in the milk and amount varies. Phenytoin and valproate are leastly excreted in the milk. Phenobarbital and primidone these two will be having high levels, resulting in sedation and lethargy and poor feeding. Coming to new onset seizures for the first time at an early gestational age, she should be evaluated and started on proper medication, usually levetiracetam. If seizures occur in second and third trimesters, it is always eclampsia unless otherwise proved. So we should start treatment with Maxhelp and then evaluate the patient. ECG MRI may aid diagnosis along with the routine investigations and PAH profile. Lumbar puncture if infection is suspected. ECG and echoes to rule out arrhythmias and valvular heart diseases. Coming to contraception, IUDs are relatively safe in epileptic mothers with which are on AEDs, because all the OC pills and hormonal pills will interfere with will have drug interactions with AEDs. Medroxyprogesterone injections appears to be effective. Copper IUCDs is the method of choice for emergency contraception. Coming to OC pills, failure rate may be higher due to interaction with AEDs. Carbamazepine and phenytoin, phenobarbital and primidone. These all drugs will, when taken with OC pills with higher doses of estrogen, or if the patient wants to take OC pills, higher doses of estrogen is required for contraception. Valproate and newer AIDs, including vigabatrin and gabapentin, lamotrigine, do not induce hepatic enzymes, and women using these medication can receive standard dose of ethinyl estradiol in OC pills. Breakthrough bleeding mandates an increase in dose of ethinyl estradiol doses and temporary use of additional method of birth control. Thank you. Are there any doubts in this topic? Any doubts?
No, ma'am.
Okay, thank you.